Power 98.7 podcast.
Right, let's move on now and talk about this important mid-level category of healthcare providers, and that is clinical associates. Clinical associates. And today in studio, I'm joined by Sanele Ngobos, the head of, the Secretary General of the Professional Association of Clinical Associates in South Africa, and is also a junior lecturer at the Clinical Associate Program at the University of Pretoria. The introduction of clinical associates has brought great relief for patients while offering employment opportunities to young people who, of course, want to get into the health profession. It also has seen an improvement and also alleviating the workloads of doctors as well as nurses in our clinics as well as our hospitals. But what is this profession really? And also, what is their role in hospitals? There are some issues, particularly with recognition from the HPCSA, but in terms of what the scope of the work, what they are meant to be doing, is unclear at this stage, and also limited training facilities. At this stage, only 3 institutions offer training, and that is the University of Pretoria, Wits University, as well as the Walter Sisulu University. But Sanele is here to give us a greater perspective on this profession, and then we'll also hear from Dr. Munyadziwa Kwinda, who is the HPCSA Ombudsman and Chief Operations Officer, and I'll speak to him in a moment on the line. Let's start with you, Sanele. Good morning and welcome to Power Talk.
Good morning, Sis Sebenzile. Good morning to the listeners at home. Good morning to all the health workers in South Africa. And specifically, good morning to all the hardworking clinical associates all over the country. Thank you for having me here. Thanks.
Shout out to everybody. Go for it. No problem. What are clinical associates?
Thank you very much. First, maybe I must start by saying thank you to PowerFM for listening when we said we want to have an opportunity to tell the nation about clinical associates. So, we're having this very good story about clinical associates. A clinical associate is a new profession that was introduced in South Africa in 2008. These are mid-level health workers. They are professionally trained currently into universities, as you were saying. They're having skills and knowledge that allow them to do much of the work that was being done by doctors. Doctors still continue doing those work, but then they were introduced just to deal with the challenge of shortage of doctors in our country. So they are trained currently into universities, and then after they're trained for 3 years, and then they do receive a degree. So they're working mostly with doctors and obviously with nurses and all the other health workers in making sure that we improve the quality of life of our people.
Let me bring in Dr. Munyadziwa Kwinda on the line from the HPCSA. Thank you very much for your time, Dr. Munyadziwa. Give us a sense of how clinical associates are recognized by the HPCSA.
Good morning, Sanele, and all your listeners. Sanele, you will know that the HPCSA is a statutory body established under the Act of Parliament, which is the Health Professions Act number 56 of 1974. And the role of the HPCSA through its professional boards, and specifically when we talk about clinical associates, we talk about the Medical and Dental Professions Board, is there to set the standards for education, training, registration, and practicing of all the health professions registered under this board. And the clinical associate is one of the professions recognized by the board, meaning that the Medical and Dental Professions Board has the regulations that relate or that defines the scope of profession of clinical associates. So at the present moment, clinical associates are a profession recognized by Council or the HPCSA to be registered with Council to be able to practice their profession here in the country.
They are mid-level healthcare providers. What does that mean?
No, what that means is that they are assistants to another profession. And that's why in terms of the their scope of the profession, and in terms of our ethical rules, in terms of the annexures. And currently, we are busy in the process of finalizing the scope of practice. There is a scope of the profession that defines the clinical associate profession. Now we are finalizing the scope of practice, which clearly stipulates that they work under the supervision of medical practitioners. Yes.
So, Sanele, on this point about the scope of practice, I mean, these are some of the issues that you've raised here, that it's 6 years now into this new profession. You're a lecturer in it, you're a junior lecturer in it. People are working on a daily basis, but essentially you don't have a sense of how you should be working and what you should be doing exactly as per the regulatory body would tell you what to do as somebody who's licensed under them.
Yes, thank you, Sis Usebe. You know, under normal circumstances, you will have a profession before it start being introduced. Usually, there should be a scope of practice that tells them what to do and what not to do. So unfortunately, with this one now, as you have correctly pointed, that it have been almost 6 years now, but we still do not have the scope of practice, and that is one of our worries. That for how long are we going to wait for a scope of practice? We know that HPCSA has taken a decision to try and work in resolving our challenges, in particular in making sure that the scope of practice is finalized and is signed. We want a document, a legal binding document, as a scope of practice to be finalized. We have been waiting for more than 6 years now, and still we do not have a scope of practice. So yes, we really want to plead with HPCSA to make sure that actually, before the end of this year, let us have it finalized. We have been asking almost a similar question for the past 5 years, and still, even now, we're saying it is not yet finalized. It will soon be finalized. When is soon? We don't know.
So, depending on where you find yourself, whether it's a clinic or a hospital, as a clinical associate, you would get there on your first day, and what you're required to do would depend on the needs of that particular institution?
Yes, definitely. But maybe I must also say that there is a draft which we are currently working on. So we're using that as point of reference to say that, to guide us as clinical associates, that what is it that we're supposed to be doing. And then there is also a job description that then tells us what to do and what to focus on.
Yeah.
Then maybe let me tell you one story. You know, I still remember now when I first qualified in 2011, and then I started working in 2012. I arrived in a hospital, and then I said, I'm a clinical associate. They said, okay, who are you? Are you a doctor? Are you a nurse? I said, no, I'm not a doctor. I'm not a nurse, but I'm a clinical associate. But they didn't know about clinical associate. People still don't know about clinical associate. But then we produced the draft scope of practice, and then together with the management, we then identify the duties that were in accordance with the need of that particular hospital.
So what do you do exactly? So you in it's just a hospital for an example. They can't get a doctor in on time. Are you able to do those jobs? I mean, are your competencies at that level, or are they somewhere in between?
Okay, maybe let me just give you a broader background of what is happening. So currently in our country, you know that we're facing a chronic shortage of doctors.
Yes.
And you also know that about 50% of our population lives in rural areas. And you know that in those that are being produced, in medical students who are being produced by universities, only 3% of them want to go, or they go to rural areas. So a professional clinical associate was introduced then to say, let us look in the areas where there's a huge shortage of doctors, like in rural areas. Let us look, how can we have clinical associates working there? So we work together with doctors, and we do most of the work that is being done by the doctors, but obviously then under the supervision of the doctors. Like, for example, so maybe a patient comes, then I'll see a patient. I take history, like doctors will do. I take history. I do examinations. I diagnose. Then I plan. And then you make a management plan to manage that particular patient. But then now, what is the difference? So now, if then you are having a challenge with that particular patient, then you have to call for doctor to come because they are supervising you. Then you can call a doctor to come and assist you, or you can have any way of communication with him to say, please, here I'm having a problem, come and assist me, and then the doctor will come and then you will assist that particular patient. But our biggest aim is to make sure that we improve the quality of health system. So one of the studies that have been done at the University of Pretoria, it shows that of clinical associates whom have been trained at University of Pretoria, who are currently being trained at University of Pretoria, 60% of them, they say they want to go back and work in rural areas. This is compared to about 13% of medical students who want to go and work in rural areas. So now, why is this happening? This is happening surely because the first thing, if you go to Sentin and you take someone and then you send them to University of Pretoria and then you train them, but you expect at the end of the day for them to go and work in rural areas, it will not happen. So with clinical associate profession, we recruit where there's a need, we recruit in rural areas, we recruit in urban areas where there's a need, we recruit clinical associates are part of the community, are part of people who are staying in that community. They understand the culture, they understand the language, and then now,
right. Let me bring back Dr. Mamunyadziwa on this point. We've moved away slightly, Dr. Mamunyadziwa, on the matter of the scope of practice. Perhaps if you could just give a sense of why it's taken so long, 6 years to get this particular body has been asking for it. What have been the delays? What are in fact the constraints to getting the scope of practice done? But also. If there's clearly a need for this, young people are being attracted to this, and of course it's serving a need in the community itself. Greater support from the HPCSA is certainly warranted, I imagine.
Maybe, let's clarify something first. There's a difference. You see, when you talk about the scope of practice and the scope of a profession, I can tell you today that we don't have a scope of practice of even medical doctors or dentists. We don't have such regulations defining the scope of practice for such profession. I just want to clarify something. When Sanele speaks, it's like a profession has to have a scope of practice. What is more important is the scope of the profession. Now, although we are in the process of defining the scope of practice for the clinical associate profession, but we must not say it had to be there. Of course, there was a need that it has to be there, but there is a scope of profession. Now, I want to go further and say, in terms of what any practitioner, and this is not only limited to clinical associates, any practitioner registered with the HPCSA, in terms of ethical rule number 21 of the ethical rules of conduct under the Health Professions Act, it states that a practitioner can only perform professional acts for which he or she is adequately educated and trained and sufficiently experienced. And this is where the issue of what a practitioner does in practice is informed by. That's why the scope of the profession, you won't find any profession registered with the HPCSA without a scope of profession of that particular profession, because the scope of profession is the one that defines the undergraduate training. Now, when one is adequately educated, trained, and further than that, sufficiently experienced in carrying out certain professional acts, then that is what a practitioner can do. Now, we bring in a scope of practice. There are very few professions registered with the HPCSA that has got scope of practice. That is when now we see we may need on the ground now where practitioners are practicing, define what this practitioner can do and what they cannot do. And that is where the scope of the practice come in. Now, when I have to answer your question in terms of why is it taking such a long time, Seven and the listeners, when you talk about the scope of, we're talking about regulations. Now, we have got processes that have to be followed. Every regulation, before they even go to the minister for public comments and so on, they have to circulate in all the 12 professional boards of the HPCSA to comment on them. After all the 12 professional boards have commented, then they go to the minister, they go for public comment, meaning that all the other professions outside the HPCSA, like the nursing profession, the pharmacy profession, or any other important stakeholders, need to have a bite on those regulations. Then when they have done that, the minister must bring them back to us with those comments, to consider those comments. Then we go back to the minister, we say we have considered these comments and this is our response to them. So it becomes
So what does it that mean then, Dr. Tamunyaziwa? I hear that we must allow the wheels of the bureaucracy to turn. But what then of the clinical associates right now who are experiencing discrimination, who find themselves with working conditions where people are not quite sure what they are there to do or what they meant to be doing, to supervise them, to assist them, and so on? How do you change that reality while the regulatory things are happening and happening slowly, it seems?
I can tell you, even though we can have those regulations promulgated, that's why I emphasize something very important in terms of the scope of the profession and Ethical Rule 21. The regulations may not solve the problem of discrimination. Clinical associates is a new profession, and it is important. I'm happy PACASA is there. It has been established, and I'm happy for this platform where at least even the members of the public can also know that we have got a profession of clinical associates. Now, what is really is the issue of advocacy. That's why the Medical and Dental Professions Board, Sebenzile and the listeners, has gone further and say, in terms of the regulations that talks about the composition of that professional board, it doesn't give accommodation for clinical associates. It's still work in progress.
Right.
But the board has gone further and resolved that because the board can co-opt two clinical associates to sit in that board, because the process of advocating for that particular profession need to start from there, to go out to all the professionals, to all the relevant stakeholders, to ensure that people understand who clinical associates are and what role they play in the healthcare environment.
All right, let's. I'll get your thoughts in just a moment, Sanele. Let's get a question from Untandla in Duduza. Hi, Untandla.
Hi, how are you, everyone?
Well, thank you.
Fine, then. So before I pose my question, then I just want some clarity. Let us say in a well-established medical center, you'd have your paramedics, you'll have all levels of nurses, you'll have some doctors. I just wanted to know, the clinical associates, what gap are they playing in terms of the openings there? At what level? I assume it would be doctor, the highest service provider, and then who follows who, so that we get to see where the clinical associates level is.
Okay, Sanele, do you want to answer that?
Yes, I can try and answer it. So what is happening, like for example, let us take an example of a casualty. Let us say we're having a doctor, a nurse, and a clinical assistant, and then we have a patient coming. So now obviously the first person who's going to see a patient would be a nurse, and then after a nurse have taken history, done vital signs and everything, then a clinical assistant will then take over in that patient. They will then also continue taking history, doing physical examinations, examining the patient, and then diagnosing the patient, and then also managing the patient. Now the difference, like I've said, it will only come like if a clinical associate is having a challenge or is having something that he does not understand, then he will then ask for doctor to come and assist.
So in short, boss, you're saying a clinical associate is qualified over and above any form of nurse you would find in the hospital.
Any form of
nurse?
Of a nurse.
I wouldn't want to to compare it that way, because then a nursing profession, it's also a profession on its own. So having someone being overqualified and less qualified, I wouldn't want to go into that direction. But what I can say is that they work together, and clinical associates have a specific role to play, which is then to take over from nurses and then work together with doctors. So we are just working together. Our dream here is to unite health workers, is to have clinical associates, nurses, and then doctors working together to improve lives of patients. That's all that we want.
That's a last bite. I hear you trying to say something. We must wrap. So a quick one for me.
Okay. And then is rural area then going to be a sport treated as guinea pigs for clinical associates?
What do you mean, as guinea pigs?
Now, he's putting more emphasis like they are ready to work in rural areas. He's talking nothing about the urban side. And if that is the case, to me it sounds as if rural areas will be used as a guinea pig for the program to be executed fairly. And
okay.
Humanitarian question.
I think he clarified that, but I'll let him answer in just a moment. And thank you for that. So listen out, Dr. Munyaziwa, just stay with us on the line, please. It's 10:30 now. We must take the latest power headlines, and then we'll continue this conversation about clinical associates. Your calls on 0861 987 000. What is their role? Why aren't they being supported better? And I'll take more of your questions thereafter. Taho?
Thanks, Sebenzile. Good morning. Making headlines at this hour, Finance Minister Pravin Gordhan says the country has done well in the first 6 months of this year to reassure ratings agencies through working with business, labour and government to present a national front. Addressing the business community at the Investment Summit in Sandton this morning, Gordhan spoke about concerns regarding a possible credit downgrade at the end of the year, low growth and youth unemployment. Gordhan has made a commitment that South Africa will retain and sustain fiscal credibility. In other news, opposition parties are demanding proof that President Jacob Zuma has indeed settled his 7.8 million rand Nkandla bill. The National Treasury yesterday revealed Zuma has paid for non-security upgrades to his private KwaZulu-Natal home. In March, the Constitutional Court ordered Zuma pay back some of the 248 million rand of state money spent upgrading his home. And former Deputy President Kgalema Motlanthe says leaders must measure themselves according to the cries of the public. Motlanthe made the comments last night during a lecture on values-based leadership at Rhodes University in Grahamstown. He says the deviation from the promise of liberation is a major concern, especially for the African child. I'll have details of these and other stories at the top of the hour.
Power traffic.
And a very good morning to you once again. Let's quickly take a look at what's happening on your roads at this hour. On the N12 westbound, we still have that earlier crash scene that's blocking 2 lanes after the Craft Road exit, and that is causing a heavy queue that starts as you get to Jet Park Road, getting past that incident. In Kempton Park on Zierfontein Avenue southbound, you can also expect some delays coming from Parkland Drive going towards the Plain Road intersection. In Crown City on the M2 westbound, the slow-moving traffic there as well that starts as you get to the Crown interchange going towards the Main Reef Road intersection. And if you're in Bryanston on William Nicol Drive southbound, slow-moving traffic that's going towards the Ballyclare Drive intersection, and a number of traffic lights out of order this morning. They're out in Hyde Park at William Nicol and Jan Smuts Avenue, so expect some delays going towards the Hyde Park corner. In Melrose at Atho Oaklands and Corlett Drive, those lights are also out. In Morningside at Calvin and Rivonia, as well as in Bruma at Queen and Albertina Sisulu Street. And over in Pretoria on the N4 Bakwena Highway, the slow-moving traffic that's on both directions passing Garankuwa this morning due to ongoing roadworks along that route. And in Centurion, traffic lights are out of order at the N14 and Jean Avenue. And remember, if you come across any further traffic incidents, tweet us at Power987 Traffic or call us on 011 014 9098. For Power Traffic, I'm Lebohang Pukela.
Power traffic. Power perspective with JJ Tamani.
Then Laibo Mabaza, who is the president of the Socialist Party of Azania.
1994 was one big fraud for black people. CODESA changed its form. When the regime went ruthlessly mad at people in Buchpatung, the language changed. It's like, no, we're no longer worried about anything. De Klerk want you to give us the day for the franchise. It was no longer about economic power. It was no longer as voting, and then all is okay.
Power Perspective, Monday to Thursday and Sunday, 9 p.m. to midnight on Power 98.7. Now, we're talking.
Hey Andre, check here. We're going to be hosting COP17. The police here at the workshop. Do we have enough coffee? No man, the site is COP17, International Trade in Endangered Wildlife. It's a conference about protecting the flora and fauna around the world. Yeah, people will be coming from all over the world.
Hey, I must hit the gym in case I meet the Scops flora and fauna.
Hey man,
I'm just joking, man, I know.
South Africa is proud to host the CITES COP17 on international trade in endangered species in Johannesburg from 24th September to the 5th of October. You should be a part of it. Go to CITESCOP17jhb.co.za for more information. This message is brought to you by the South African government.
Power Talk on Power 98.7. Weekdays, 9 a.m. to midday.
25 to the top of the hour here on Power Talk. Sebenzile in for Iman this morning. Thank you very much for staying with us. We are still in conversation about clinical associates, what their role is as mid-level healthcare providers. Sanele was in studio with me and is the Secretary General at the Professional Association of Clinical Associates in South Africa, PCSA. And he's also a junior lecturer at the Clinical Associate Program at the University of Pretoria. On the line, joined by Dr. Munyadziwa Kwinda, who is the Ombudsman and Acting Chief Operations Officer at the Health Professions Council of South Africa, the HPCSA. Now, you noted a question there, Sanele, of course, about your role in the rural areas, but I see there are a number of other questions coming through, so I'll take those first, and then I'll get to both you and Dr. Munyadziwa to respond in just a moment. Those numbers again, 0861 987 000. David in Ngwamhlanga, I'll start with you. David, I understand you're a doctor.
Yes. Yes, morning Sebenzile and morning to your guests. I'm a general practitioner who is I'm running my own practice, but I also do sessions at the government hospitals, at the government hospital in Guamslang. Now, my challenge is that these clinical associates were recently introduced. And I've been working in that hospital for more than 10 years. And then sometimes you go and you have a call, you go to the hospital. Now there's this person that they call the clinical associate. And then you find that he's just following you around and you don't know exactly what is it that this person is supposed to do. I mean, is this person allowed to prescribe drugs? Is this person allowed to draw blood? Is this person allowed to suture? These minor procedures. So I like these people, your guests, to be practical, so that I, for one, would know in future what can I utilize a clinical associate for.
Quick one, David. When they were introduced to you, was there any training, any introduction of what to expect? Or you just started seeing them hanging around?
No, I don't know that. Perhaps maybe for the doctors who work full-time in the hospital. But for us as general practitioners, no, we were not introduced to them. Yeah.
All right, David, thank you for your call. David in Wamhlanga there. Let's also hear from Lorika in Garangoa. Hi there.
Morning, Sanele, and your guests.
Morning.
I'm a bit confused. We have doctors, and then we have professional nurses, then we have nurse aides, and of recent there has been community health workers that have been introduced. Now they are clinical associates. I hear it's like they are all over the place. They can do a bit of a doctor, a bit of those two nurses, a bit of community health workers. Where in do they fit in? And I think it is a good idea to have another extra profession into the health system because we are short of staff. But they need to have that scope of practice that is talking about.
Thank you.
Where do they fit in there?
Yeah. Thank you, Lorika in Garangoa. Samuel in Krugersdorp.
Hey, leadership, how are you?
Well, thank you, Samuel.
I'm fine, madam. Thanks for bringing that gentleman. I just want to know, this is my first time to hear about it. I've always been overthought that when I go to the hospital, I meet a nurse and then immediately I meet a doctor. So I have two questions. What do they wear at the hospitals? Do they wear white coats, the way of closing of nurses so we can know who they are. And then secondly, I need to know this course. What is their course called at the varsities? Is it degree of what, bachelor of what? So that we can maybe know what exactly is happening. Because now I'm getting worried that sometimes I might meet a clinical psychologist, clinical associate, thinking that is a doctor.
All right, Samuel, thank you very much for your question. Let's start with you, Sanele, and then I'll get some responses from Dr. Muyadzi.
Yes, thank you very much to all the questions. Let me first start with the first caller who asked if we're only working in rural areas. And let me make a practical example about Tshwane. You know, in Tshwane, we've brought so much change. Let's look at, for example, we're doing a study where we're looking at the role of clinical associates in Tshwane in doing voluntary medical circumcision. And then in that study, we have seen that 87% of circumcisions in Tshwane, they have been done by clinical associates. So this then does show you that clinical associates are not only working in rural areas, but they are working where there is a need. Obviously, there is a need mostly in rural areas. So we have a huge role to play in also in urban areas. We are in many hospitals in urban areas. But then also maybe to also answer a question of how do we get to be identified. So like all the other health workers, you'll find us with obviously the name tags that are written, our names and our profession, which is clinical associate. We do wear scrubs, as Sanele can see that I'm now on.
He's wearing a white coat.
Yes, I'm wearing a white coat.
Are you wearing scrubs under that?
Yes, I'm also wearing scrubs. So we also do that. And then also the profession itself at universities. So this is it is known as a Bachelor of Clinical Medical Practice. So how can you apply? So it currently, as I've said, it is in 3 universities: University of Pretoria, Vet University, and also at Usasulu University. So for matric students who have symbol Ds in math, science, and biology, they can apply for this profession, and then they can be accepted. So, but what I also want to bring on here is that as a profession, like one of the callers mentioned that people don't know about the profession, and we want to say that we want to work together with the Department of Health in making sure that our people start understanding this profession. This profession was introduced by National Department of Health, so it is also the responsibility of the Department of Health to make sure that they advocate for such profession, they educate our people about this profession, they tell our people about this wonderful profession, they become proud of such a profession. This is a profession that have changed lives of so many people.
Right. So just before I go, Dr. Muyadzi, you mentioned that you do procedures such as circumcision. What other procedures can you do that you don't necessarily need a doctor to do?
So it's a range of procedures. We can do IV lines, we can do phlebotomy, we can do even things like a protep, CPR, we can do things like even ICD, intercostal drainage, which is one of the invasive and a very strong procedure. So it's a range. So we have a long list of procedures that we can do as clinical associate.
Dr. Muyadzi, your thoughts on the questions that we have received?
Yes. Let me just respond from the side of Council 7 and the listeners. We have accredited all the medical schools in South Africa to provide the Bachelor of Medical Practice. And as Sanele is saying, for now, it's only those 3 universities or 3 medical schools that are providing the program. But from the side of Council, in terms of the regulations, those qualifications, we have accredited them for provision of this particular training in our 8 medical schools in the country at the present moment. Now, in terms of what was said about the hierarchy, and I think Sanele put it very clearly. Basically, and let me address it this way, Serenzile. The challenge that we always have because of the shortage of doctors, we end up having what we call task shifting, where although a nurse has not been trained to do a particular thing, you find that because of the shortage of doctors in our institutions, nurses end up being assistant surgeons. In certain areas, nurses are the ones who are doing circumcision. Now, the clinical associates have come in to say, that's why, as Sanele has said, when you've got a shortage of doctors, these people are trained to do certain things that doctors can do under the supervision of the doctors. And what that means is that although the doctor may not be on site, the doctor takes liability for all the actions of the clinical associate. Of course, they can, in terms of their training, they can prescribe drugs, but until we have a schedule developed in terms of the Medicines and Related Substances Act, pharmacists cannot dispense a script of a clinical associate. We are working on that so that the minister can make a schedule of the drugs that clinical associates can prescribe so that pharmacists can dispense. So I know the scope of practice and the contents of the scope of practice.
Sure.
They can do lots of things that doctors can do under the supervision of doctors, and that is informed by their training. Now, on the issue of a GP who does sessions in a hospital and see this person following him and he doesn't know how to use the person, you will agree with me that really is the problem of the hospital, where they need to introduce their clinical associates to all the people who work there and be clear as to what these people do. And that can be, and I agree with Sanele when he says this program, of course, was introduced by the Department of Health. We came in as a regulator to ensure that it's regulated. And the Department of Health must also come up and bring the issue of advocacy to all our health facilities in terms of the role of this profession.
Just clarity on accountability and who takes responsibility, whether there's negligence or something goes wrong. Does that then rest on the doctor?
Yes, Sebenzile, it rests on the doctor. We are very clear in terms of how we define supervised practice. Only the clinical associate will be responsible if the clinical associate was grossly negligent. And what that means is that the clinical associate did not recognize his or her limitation and call a medical practitioner to come in and try to do something that they are not adequately educated and trained to do. And that is how we define gross negligence. But otherwise, the medical practice, that's why a clinical associate who is working should know who is my supervisor when I'm carrying out my clinical practice. That is what supervised practice means.
Let me take more calls. Rebona, you're in Potchefstroom. Thanks for your call. And you've been a clinical associate for 5 years.
Yeah, actually for 4 years. This is my fifth year now. Yeah. I graduated with Sanele Ngobo. He knows me very well. I just wanted to clarify. I don't have a question, but just to clarify on the question that Ntlantla asked, because I came late at home and then I had when I took on my radio, Ntlantla was calling asking about the gap that the clinical associates are feeling within the healthcare system.
Yeah.
So Sanele tried to answer it, but he didn't really clarify and give a clear answer. The answer is clinical associates, yes, they are more qualified than a nurse.
You're more qualified than a nurse?
They are more academically qualified than a nurse, unless the nurse has other specialties that she or he did in terms of midwifery and the matrons and all that, because nurses have their own grades there. Unlike us, we don't have the hierarchy or the grading in terms of our profession. But then, according to our training from medical schools, we are a bridge between a nurse and a doctor. I don't know if you understand. We are a bridge. We fill the gap between a nurse and a doctor.
Right.
So yes, the most senior person in the clinical setup will be a doctor, then a clinical associate, as a supervised profession by a doctor, then a nurse.
Okay, Rebone, where do you work currently? Are you in urban areas or?
I'm in urban areas. I'm in urban areas in Potchefstroom Hospital, where at first I was supposed to be put at Venderstop Hospital, which is a rural area, which is a district. Actually, the program was designed for rural areas where there's a serious shortage of doctors. You understand me? So the program was for that. It was not really for urban areas where most of the doctors are. most of the doctors don't want to be in the rural areas. So there's a serious shortage that's affecting the management of patients and all other things in the rural areas. So that is what the program was designed for, so that the clinical they can be integrated into rural areas to fill those gaps where, let's say, we have, I did my practicals in Mpumalanga, in Mbuleni Hospital, where the hospital would only have like 8 doctors and also sessional doctors doing calls, sessional doctors doing calls from GPs and all that. Yeah, so it's a serious crisis.
Sure, Rebone, let's leave it there. Thank you for your call. Senzo in Pretoria West, you're a first-year clinical associate. Hi.
Hey, hi, Unjani.
Ngiyaphila unjani Senzo?
Hi, ngiyaphila.
What has been your experience so far in the program?
Firstly, I would like to indicate that I'm a first-year student at University of Pretoria, and I am in love with this profession. And I'm also coming from rural areas where there is a serious shortage of doctors there.
Where do you come from, Senzo?
I'm coming from KwaZulu-Natal.
Gopi?
Mtubatuba. Yeah. So what my concern about this topic, when we go there to the hospital for clinical, we find that it is very difficult, even to practice there with other medical students that we find there. Because some of them, they don't know about us, even the nurses, the doctors, we are mistreated, being underestimated.
So you've already started your practical, so it's not just classroom or lecture hall work.
In this program, what is happening, first six months from January to June, you attend classes, then from there, you attend classes and then doing practicals at the same time.
Okay.
Yeah, so I'm already starting with my practical.
And your intention when you're done is to go back to Mtuba to assist there?
Yeah, is to go back to where I'm coming from to say we are experiencing the real shortage of doctors there. So that's what ebengifisa ukuthi kwenzeke ukuthi like izinto zihlele ngendlela nanokuthi ezinye izinto eziqeda umfutho okanye namandla ukuthi like when we hear ukuthi if you are doing this, if you are a clinical associate, some of the benefits athola ama-workers register ngaphansi ka-government, then wena awukwazi ukuwathola simply because this is scope of practice sethu asika-practice. So lokho kuqeda amandla njengabafundi abazoba ama-clinical associate.
Senzo, let's leave it there. Great point that you're mentioning the benefits and the kind of support that you are getting, and I'll get Dr. Munyadziwa to answer that. Just finally, Nomthandazo in Arcadia, are you also a clinical associate? Hi.
Morning, how are you?
Great, thank you.
Yes, I'm Nomthandazo Shabang, a first-year clinical associate at the University of Pretoria. Yes, what I want to clarify is like our scope of work. I don't get to understand how medical doctors say they don't know what we are supposed to do. Because in hospitals that we are working there, that we are supposed to do, the staff there knows about us. They know our line of practice. They know our job description. Like when he said he doesn't know that we can suture or we can draw blood and inject. Those are the minor procedures that we do. We are trained to alleviate the workload of doctors. Like when it comes to rural areas, you will find like the guy who called like in a hospital there's 8 doctors. How many wards and what about the casualty and the OPD? You will find us in the casualty and in the OPD will be attending chronic patients. We'll be giving them their medication, managing them on those monthly basis as they come to see us. If a patient is injured, we can suture that patient. If a patient comes into the hospital dehydrated or they are in trauma, we can if they are trauma patients, we can easily prescribe hearing as lactate. We don't need a doctor for that. A doctor doesn't need to come when he's supposed to attend the surgery and leave that just to tell me to give that patient ring as lactate. I know in trauma patients we do that. I'm authorized to do that in my line of work. Sure. I can suture a patient. That's my line of work. So I don't understand when the doctors say they don't know what we are supposed to do. We are supposed to do those minor skills so that doctors will have enough time to do the extreme procedures. And we are there to alleviate. And yes, we work we work above nurses simply because we are trained more practically than nurses.
Sure.
From first year, we are trained in hospital. We are already suturing. We are already managing patients from first year. So at the end of the 3 years, I'm more practical than a nurse.
Right,
a nurse will do the other things, but I will be more advising the nurse on other things after she has taken vitals and those things.
Nomtandazo Nyabonga, let's leave it there, dear. Nomtandazo on the line there from Arcadia. All right, as we wrap up here, Sanele, last part from you. What is your ask to the HPCSA? Essentially, what do you want them to get right? We've spoken about the scope of practice. One or two other challenges as well in terms of the kind of benefits that you guys are getting.
Yes, thank you very much. So now, we have said this is the future of the South African health system. But now it cannot be a future when Department of Health is ignoring it. We currently have no a career path. Currently, clinical associates are being underpaid. They are being paid about 12,000 rand a month after deduction. What is happening? What are we saying to the people who are being helped by clinical associates? Currently, clinical associates are not getting role allowance. Currently, clinical associates are not being paid as they should be paid. Currently, clinical associates are not being given committed overtime. So now, are we saying that the shortage of healthcare workers is only during the day and not after hours? What are we really saying to the public? Currently, we have heard that some provinces are saying now they're no longer going to give clinical associate bursaries. We want answers. We want to know what is happening. What is Department of Health planning with this wonderful profession? What are they going to do to make sure that this profession allow people to change their life? I'm one of those that my life was changed through the profession of clinical associate.
All right, Sanele, I must leave it there. Dr. Munyaziwa, just a last bite from you as well. What do you have to say to PACASA? And also, I suppose, what can the Department of Health, I know you don't speak for them, but in working with them to assist these professionals?
Yes, maybe let me just clarify something. The reason why we have got scope of profession of the different health professions, it helps us not to say another profession is less qualified than the other profession. You don't have any other profession lower than any other profession. Like you cannot say nurses are less academically qualified than clinical associates because nurses are trained for nursing care. Now we need to be careful when we deal with issues like that. Secondly, what I want to say, Sebenzile, is true. The issues that Sanele is raising are issues that PACASA need to engage with the department constructively, and I'll tell you why. Remember, when you talk about committed overtime at the present moment, it is only for medical doctors and dentists. Clinical associates are not included there, but clinical associates are not excluded from the conditions of service in terms of the Basic Conditions of Employment Act. If they are working overtime, they'll be paid overtime, not committed overtime, because committed overtime is for medical doctors and dentists. So we need to be careful how we approach these things, and there is a constructive way of approaching it. Of course, issues of conditions of service are outside the jurisdiction of the HPCSA, but as our Act empowers us, we do advise the minister on such issues, and that's why we do have clinical associates in the Medical and Dental Professions Board.
All right, Dr. Munyaziwa, appreciate your time with us. We do have to leave it there. Dr. Munyaziwa Kwinda, HPCSA Ombudsman and Acting Chief Operations Officer. And thank you, Sanele, for joining us in studio. Sanele Ngobo, General Secretary at the Professional Association of Clinical Associates in South Africa, PACASA.
Power 98.7 Podcast.